Today's lecture will be on the scapula. When we're looking at the scapula, some just basic understanding of the scapula is that it's considered a scapulothoracic joint. It's not a true synovial joint. Its movements is going to be greatly dependent upon the muscles in the posterior compartment. And also it's dependent on two joints, the acromioclavicular joint and the sternoclavicular joint. So all scapular movements are going to be dependent on these two joints. When we're looking at just general movement of the scapula, so again, it's not considered to be a synovial joint, but it has movements. The scapula itself, it can adduct or move closer to the midline, and adduct, abduct, moving away from the midline, equally at about 25 degrees. When we look at upward and downward rotation, we're usually looking at the inferior angle. So when you're looking at upward and downward rotation along the frontal plane, it's usually about 60 degrees. And then finally, when we're looking at elevation and depression, or returning back to its original position, we usually look at elevation at about 55 degrees, and then returning back to its normal position would be also 55 degrees of depression. So again, when we do look at all these movements, we're going to see that they're all based off of two joints. The first one that we're going to look at is the sternoclavicular joint. So we're attaching the manubrium of the sternum with the clavicle. We see that it can actually protract and retract at about 15 degrees, and its movement is going to be in elevation. So we're looking at a 45-degree range of motion in elevation. And it can also do depression, but it can only do depression at about 5 degrees. The other one that we'll talk about is the acromioclavicular joint. So this joint right here. When we're looking at the acromioclavicular joint, we're looking at the acromion versus the clavicle. Its most important movement is going to be a sliding or a gliding. Sliding and gliding is important because we can get about 20 to 30 degrees of motion at the acromioclavicular joint. And the last one that we should mention is when we see injury rates or areas of injuries that are highest is going to be the corticoclavicular ligaments. So these corticoclavicular ligaments, the trapezoid and coinoid ligaments, these have the highest rate of injury, and usually we see this injury occur when the hand is above the head or when the shoulder joint is in flexion. So again, when we're just looking at some of the general characteristics, we can see here this is the infraspinatus fossa. We will be speaking a lot about the inferior angle, the acromioclavicular joint, and then of course the supraspinatus fossa right here. So these are the key posterior landmarks. We mentioned this in the shoulder joint lecture, but the glenoid cavity or glenoid fossa, we know that the humeral head, only 1/3 of the surface of the humeral head sits inside of the glenoid fossa. And the picture that I just drew would be the fibrocartilaginous joint of the labrum. The labrum provides a suction cup. So when we're looking at the shoulder joint, we can see that we have a lot of mobility with a decreasing stability. So the shoulder joint and the shoulder girdle work as one. So when we're looking at the shoulder girdle muscles, first when we're talking about the shoulder joint, we're looking at anywhere from 0 to 90 degrees. So when we mentioned earlier with rotator cuff musculature, their job from 0 to 90 degrees is to properly align the shoulder joint and the glenoid fossa. When we're looking at the shoulder girdle muscles, particularly most of the shoulder girdle muscles are located in the posterior compartment, including the deltoid. We're looking at power muscles that allow for ranges of motion to increase from 90 to 180 degrees. These shoulder girdle muscles are also important to help stabilize the shoulder joint when reaching overhead, for instance, like pulling things off of a high cabinet. So their job is to exert force. They contract to maintain the scapula in a relatively static position. So when we're looking at the scapulothoracic joint, or when we're looking at regional interdependence, we know that your T-spine should be mobile, your scapula should be stable, and your shoulder joint should be mobile. So when we're looking at upward and downward tilts, or lateral tilts, or medial tilts, so when the shoulder joint is going in during abduction, we see that the scapula rotates about its vertical axis, meaning that the medial border and anterior movement of the lateral border. So we will have different types of tilts when we're talking about this. When we see extreme adduction, this would be a medial tilt or returning from a lateral tilt. The one that's most confusing, I already drew this in, is the anterior tilt and the posterior tilt. You can view the anterior tilt very similar to the anterior tilt of the pelvis. So if we're looking at this, I've already drawn this out. This is an anterior view, a posterior view. This would be the scapula. This area right here would be the inferior angle. So when we look at an anterior tilt, what we're seeing is that the inferior angle is moving posteriorly, so it's moving into the back of the body, and we see that the inferior angle is also rotating up in a superior position. Most of the time we see this occur in any hyperextension of the glenohumeral joint. Again, this is with a posterior tilt, we're looking at downward rotation. So this area right here would be the inferior angle. This would be the posterior compartment and the anterior compartment. During flexion or hyperflexion, what we see the inferior angle is first moving into the anterior compartment, and it's also rotating up or superiorly. We usually again see this with any type of flexion motion. So when we see the synergy, synergy is again going to be with the glenohumeral joint. We're going to be looking effectively at how things are working from 0 to 180 degrees of flexion of the shoulder joint. So we usually give about a 10-degree difference as far as an allowance of a decreased range of motion. We should see someone at least at 170 degrees of flexion. So the first part would be from 0 to 90 degrees. We should see that the rotator cuffs are musculature is putting the head of the humerus and the glenoid fossa in an appropriate position. So the scapula is important because as you're going from 0 to 90 degrees, what we should see is that after that, the larger muscles are what allow us to go from 90 degrees to 180 degrees. So for example, when we're raising our arms off to the side, we see, if we're going to go through all of the general musculature activation, we should see the supraspinatus, which does abduction, and the middle fibers of the deltoid begin the movement of the glenohumeral joint. We see the serratus anterior and the middle and lower fibers of the trapezius helps rotate the scapula. So this synergy or working together will allow for greater force production in the movement of abduction of the shoulder joint. So finally, this last diagram I think is the most important. It gives you two things. The first one is over here we see it gives you the different directions. So we have elevation, adduction of the scapula, abduction of the scapula, depression of the scapula. We have upward rotation and downward rotation of the scapular joint along the frontal plane. So when we are looking at these, this diagram is telling you first is when we're looking at upward rotation, it's predominantly the trapezius, the middle, and the lower fibers. When you're looking at downward rotation, and the serratus also. When you're looking at downward rotation is going to be predominantly going to be the rhomboids and the pec minor. And again, just following the graph, if we were looking at depression, we're looking at the lower fibers of the trapezius and the pectoralis minor. When you're looking at adduction or adduction, you're looking at the rhomboids and trapezius, the middle and the lower. When you're looking at elevation, you're going to be looking at upper and middle fibers of the traps and the levator scapulae. And when you're looking at abduction, we're going to look at serratus anterior and pec minor. So with that, if there is one dysfunctional area that we most often see in the scapula, it's going to be more on the lateral compartment. I'll just erase these real quick. And what I mean by that is what we're going to see is during upward rotation or during any type of abduction, the main dysfunctional muscle that we tend to see is going to be the serratus anterior. Weakness in serratus anterior usually causes a winging of the scapula, and a winging of the scapula means that the medial border is rotating away from the surface of the upper back. So that's usually associated with the serratus anterior. So that concludes the shoulder girdle structure lecture, and thank you very much.